Now let's talk about the effects of strokes in various regions of the brain. You've got a great table here organized by anatomical location, anterior and posterior circulation, and the communicating arteries. Each important vessel is listed on the left, with detail about the effects of a stroke there on the right. But keep in mind, test questions will be more likely to give you the symptoms, and you'll need to sort those into one or multiple anatomic regions, just like your patients will need you to do in the future. Now, let's start with the anterior circulation. The MCA, as we mentioned, supplies the lateral brain, so the motor and sensory cortices will be affected, along with Wernicke's and Broca's areas. This will give you contralateral paralysis and numbness in the upper limb and face, and possibly hemi-neglect. Refer back to the homunculus drawing if you need a visual reminder of the face being located more lateral. The ACA is medial, so you will have effects on the motor and sensory cortices that supply the lower limb. Last on the anterior circulation is the lateral striate artery. We haven't mentioned this one before, but it is really critical. The lateral striate is a common location for lacunar infarcts, which are infarcts that occur secondary to long-term hypertension. Because this vessel supplies the striatum and internal capsule, you can have severe hemiparesis and hemiplegia. Now we'll move on to the posterior circulation, where we encounter the medial and lateral medullary syndromes. The medial medullary syndrome is caused by a lesion in the anterior spinal artery, or ASA, which runs down medially and ventrally. Infarction of the ASA affects the corticospinal tracts before they decussate in the medullary pyramids. The medial lemniscus as it travels from the spinal cord to the thalamus, and also the cranial nerve 12 nuclei. Thus, what lesions would you expect? Well, contralateral hemiparesis, impaired contralateral proprioception, and ipsilateral paralysis of the tongue, so the tongue will deviate to the side of the lesion. Strokes in the pica are known as either Wallenberg syndrome or lateral medullary syndrome. They're typically caused by a proximal vertebral artery occlusion. Many nuclei are affected, including the spinothalamic tract and its spinal trigeminal nucleus, the nucleus solitarius and ambiguous of the vagal nerve, the descending sympathetic tracts, and also the inferior cerebellar peduncle. So what do you expect if each of these nuclei are lesioned? Well, vestibular nuclei, of course you'd get vertigo, vomiting, nystagmus, and diplopia. Lesioning the spinothalamic tract would lead you to contralateral loss of pain and temperature of the body. Now how about the spinal trigeminal nucleus? Well, that will give you similarly a loss of pain and temperature, but the difference is that it will be ipsilateral and will affect the face. Now the nucleus ambiguous, a lesion there would give you hoarseness. Nucleus solitarius would lead to a decreased gag reflex. The descending sympathetic tracts could give you ipsilateral Horner syndrome, and a lesion in the inferior cerebellar peduncle could give you ipsilateral ataxia. Now the hoarseness we mentioned, which was related to nucleus ambiguous, is quite specific to pica lesions. The last of the lesions in the posterior circulation we'll mention is that of ICA. ICA also supplies many territories, so strokes there can have a variety of different symptoms. Areas affected include the vestibular nucleus, spinothalamic tract, the dorsal cochlear nucleus, the outputs of cranial nerves 7 and 8, the middle cerebellar peduncle, and also part of the cerebellar hemisphere. So, what symptoms might you expect with these sorts of lesions? Well, lesion to the vestibular nerve and nucleus, as we mentioned, would lead to vomiting, vertigo, and nystagmus. If you were to lesion cranial nerve 7, you would end up with an ipsilateral facial paralysis, but also reduced lacrimation, salivation, taste from the anterior 2/3 of the tongue, as well as loss of the corneal reflex. Lesions in the spinothalamic tract, as we mentioned, would give you contralateral loss of pain and temperature in the body. Lesions to the middle cerebellar peduncle and cerebellar hemisphere, of course, would give you some ipsilateral ataxia. Lastly, the two communicating arteries. Here we have usually Berry aneurysms and not strokes, but they're on the same page anyways. ACOM aneurysms will produce a visual field defect, whereas PCOM aneurysms generally cause a third nerve palsy. This will cause the eye to go down and out. As we just mentioned, berry aneurysms are very common at the Circle of Willis. You can see them in these two different images. Here, radiographically, and here on gross pathology, you see a massive aneurysm underlying the very delicate vessels that compose the Circle of Willis. About 30% of berry aneurysms occur at the anterior communicating artery. About 25% are at the PCOM, and 20% are from the ACA. Berry aneurysms are quite prone to rupture, which can lead to a subarachnoid hemorrhage. The risk factors for aneurysmal rupture include hypertension, smoking, and advanced age. And people with PKD, Ehlers-Danlos, Marfan syndrome, they're all predisposed to developing these aneurysms. Charcot-Bouchard microaneurysms are another type of aneurysm occurring in the lenticulostriate arteries to the basal ganglia and thalamus. When these aneurysms rupture due to chronic hypertension, a hemorrhagic stroke ensues. Next, let's review intracranial bleeds. Epidural hematomas are a collection of blood between the dura mater and the skull. And what causes epidurals? Well, most are caused by disruption of the middle meningeal artery, usually due to a fracture of the temporal bone by head trauma. Here you can see a site of fracture. Epidural hematomas are characterized by a lucid interval of several hours. Eventually, the hematoma begins to compress the brain, leading to elevated intracranial pressure and transtentorial herniation. What would you see on CT? Well, on CT, you'd often see a lentiform hematoma, sometimes called a biconvex disc, because the blood is limited by the strong dural suture lines. Subdural hematomas occur in the potential space between the dura and the arachnoid layers. What causes subdurals? They're usually caused by rupture of the bridging veins after a trauma. The people who are most susceptible to developing subdural hematomas are the elderly, because they often have diffuse cerebral atrophy that allows the brain to move more freely in the skull, which leads to injury to those bridging veins. Shaken babies, alcoholics who fall, and also those with brain contusions are at risk. Subdurals can be chronic, developing over the course of several weeks, or acute, developing immediately after injury. What do you see on CT in a subdural hematoma? Subdurals are characterized by a crescent-shaped collection of blood causing mass effect because the blood flows relatively freely between the two layers. Acute subdurals are hyperdense, but chronic subdurals can be isodense or hypodense, depending on the stage of blood clotting. There is generally midline shift. Now, in contrast to epidurals, these cannot cross the falx or tentorium. A subarachnoid hemorrhage occurs in the space between the arachnoid and pia layer, which contains the major blood vessels of the brain. And what causes subarachnoids? Hemorrhage occurs when an aneurysm or AVM ruptures. Risk factors for aneurysm development that we already mentioned include polycystic disease, Marfan's, hypertension, smoking, and more. Now, what is the patient's chief complaint? Well, the classic description is the worst headache of my life. You should particularly worry when it's of sudden onset. Patients can often remember exactly when it started. They may also have meningeal signs like nuchal rigidity and photophobia. The CT may show hyperdense blood. This image shows blood that's filling the star-shaped suprasellar cistern. What's the most accurate way to diagnose subarachnoid hemorrhage? Well, the gold standard for diagnosis is a lumbar tap showing blood or xanthochromasia, meaning the yellowish color caused by blood breakdown products, but usually it's diagnosed on a CT. Once you've treated these patients acutely, they should be started on a calcium channel blocker to reduce the risk of arterial vasospasm, which can lead to cerebral ischemia or infarction. A parenchymal hemorrhage is most often caused by hypertension, although amyloid angiopathy and certain toxic metabolic causes are occasionally at fault. Small vessels are affected, such as the lenticulostriate arteries, and these hemorrhages are most common in the basal ganglia and in the internal capsula. The CT of intraparenchymal hemorrhage will show a rounded, hyperdense area, as seen here. Ischemic brain infarcts occur usually in the context of cardiovascular disease. There is decreased brain perfusion, which causes irreversible damage after about 5 minutes. The most vulnerable areas in the brain are the hippocampus, the neocortex, the cerebellum, and of course the watershed zones. The reaction of the brain to an ischemic insult is the same pathogenesis for all brain remodeling after injury, with production of red neurons and activation of gliosis. Let's review the major causes of ischemic brain disease. One cause of ischemic brain disease is atherosclerosis. Thrombi can break off of a plaque at the common carotid artery and lodge into a subsequent smaller artery. Hemorrhagic stroke is included here because it is a common sequela of ischemic brain injury. You can think of it this way. When an area is ischemic and thus injured, the vessels are more fragile and less able to do their job. Thus, the vessels are extremely vulnerable to slight increases in blood pressure, which can allow hemorrhagic stroke. Ischemic stroke occurs when emboli lodge into a vessel. The classic cause of ischemic stroke is atrial fibrillation, which is why all these patients are on anticoagulants. But any valvular problem or structural heart defect allowing right to left shunting can precipitate emboli. Think about the different ways for blood clots to get to the brain. An infected valve can shoot off emboli to the brain, a deep vein thrombus can travel through a patent foramen ovale to the left heart and travel to the brain, etc. So, what is the treatment for ischemic stroke? Well, the treatment for ischemic stroke is to give TPA if the onset of symptoms occurred within 3 to 4 hours. After about 4.5 hours, according to studies, the risk of an intracranial bleed with TPA outweighs the possible benefits of its use. Now, a TIA, or transient ischemic attack, is temporary brain ischemia, usually causing focal neurologic deficits that last about 10 minutes. Some can last longer, but by definition, they should resolve within 24 hours, or else it would be considered a stroke. These patients get a complete workup to search for treatable sources of emboli, but generally they're just prescribed low-dose aspirin. You can see ischemic brain injury on CT after 24 hours, but with MRI you can see it within 30 minutes. The real reason to do a CT, however, is typically to rule out hemorrhagic stroke in order to safely give TPA.